Hello, good morning, and thank you for opportunity to present this very important and wonderful topic. And it is very useful topic for the postgraduates. That is the Glasgow Coma Scale, Four Scale, and PECARN rule. Like Glasgow Coma Scale is conventionally we are using for last many years. Just got three component: eye opening, response to eye opening, verbal response, and motor response, which has got aggregate 15 points. And depending upon this point, you will also classify the brain injury into minor or mild, moderate, or severe. But in the recent years, in 2018, in Journal of Neurosurgery, this GCS is updated and thoroughly revised, and they made it that approach is simplified and they corrected what are the lacunae it has got so far. So according to the new approach, they made it in a simple 4-level approach to assess GCS. The first one is you just assess for the check for the factors that interfering for communication, ability to respond, and injuries. The second step in this is like looking at observe. First you check it, then observe for eye opening, content of speech, and movement of right and left sides. Then the third step, you stimulate. You stimulate your patient, for the sound and physical. Sound for the spoken and shouted request, and the physical you do pressure on fingertip, trapezius, or suborbital notch. According to the three, the fourth step is rate whatever the result you are getting out of this assessment. This is a simple four-step assessment. GCS is the new one, and one important thing like. You should previously you are as you are applying pain to get the response, and hereafter you should not apply any painful stimuli. What you can do only a pressure to elicit the response. So the usual size to apply the pressure are the fingertip, the trapezius, or the supraorbital notch. And how long you apply this pressure? You have to do 10-second maximum. And like the one of the major drawback of the Glasgow Coma scale is there are so many confounding factors which mislead the results of the GCS. This include drugs, particularly anesthetic, sedatives, neuromuscular blockade agents, etc. And also sometimes with the cranial nerve injury, intoxications like alcohol or drug, hearing impairment, a patient on endotracheal tube or on tracheostomy tube. Again, sometimes patient with limb or spinal cord injury, dysphasia, pre-existing disorders like dementia, psychiatric disorders, ocular trauma, language and cultural related issue, orbital swelling. All these will are the some of the confounding factors that rendering one or more components of the Glasgow Coma scale. In that case, what you have to record, you have to just put it NT. NT means not able to test or not tested, not testable. So recently, the Journal of Neurosurgery again added a few more things in the assessment of the GCS score. One is like they added a pupillary reaction. That is what is called a GCSP. In GCSP, what you can do that the pupillary reactivity score, that's the PRS, is subtracted from the total Glasgow Coma scale total score. So a GCS minus P is equal to, that is a GCSP. Here, that GCSP is here, it is ranging from 15 to 1. So in fact, what you will do is you are looking at the unreactiveness to the pupils unreactiveness to the light. So you can grade in, like, suppose the both the people are unreactive, you will give the score of 2. If only one pupil is unreactive, you will give the score of 1. And if the both the people are reactive, you will give the score of 0. So this way you have to add that GCSP. In addition to that, again, new GCS system, they added age also, because that age is the one of the risk factor for the death after traumatic brain injury, and this death rate is increasing when the age is increased. Similarly, all the ages, again, the risk of death increase due to GCSP is decreases. And so what is the most important thing is, like, with the addition of the age along with the GCSP, there will be charts or the nomogram which shows the risk of death, and also there are it's a separate normogram to predict that favorable outcome in the 6-month period of the post-traumatic injury. So this is the one normogram which predict the mortality, where you can see that age is plotted against GCSP. This another nomogram here. This is the one which predict that the 6-month favorable outcome following a traumatic brain injury, and also also combining them to convey the information graphically about the risk of mortality or the prospects of the independent recovery after head injury. So another thing what we have, the new recommendation added along with the GCS, people reactivity in age CT scan finding. So the CT scan finding is again it is a simple extension of the prognostic chart that can be made by stratifying original starts into the CT scan grouping as in 3 group. That is the no patients with a no CT scan finding, or patient with 1 CT scan finding, or patient 2 or more CT scan finding. So this here, they created that 2 sets of 3 predictive charts that's based on GCSP plus patient age and number of CT scan abnormalities. And these charts, there are also charts for no CT scan abnormality, or CT scan no with 1 CT scan abnormality, or 2 or more abnormalities. See, this is these charts are predict the favorable outcome, and also this will be helpful as to us for deciding, or as helping us for decision making and communicating the predictive information to the clinicians, patients, and their caregivers. So as far as again GCS is concerned, when the case is a pediatric, that in a case of child, particularly in infants and children, this is slightly different. Particularly, the difference is seen in verbal response. This gross reference, what you can see is in the response is seen in the infants. Where you see we will assess that verbal response by smile and coos, or the cries and consonable, or the persistent inappropriate crying or screaming, or the grunts and agitated result, or no response like that. So the pediatric GCS is something different from the adult GCS. Now we are coming to the force score. Force score has got the four system of scoring that include eye opening, then eye opening, muscle response, motor responses, then brainstem reflexes, and respirations. So see, the brainstem reflexes are again in the all are in the 4 skill measurings also there. In the brainstem reflexes, there's they look at into the pupil reactivity and corneal reflexes, whether it is present or not, and whether it is present in one eye, and when the next grade is coming, pupil or corneal reflexes are absent, or both are absent, or no reflexes at all. Again, coming to the respiratory responses, they are looking at regular respiratory pattern, or chain stop breathing, or irregular breathing, or it triggers the ventilator or breath above the ventilator rate, and apnea. So something we have to know, like the basic difference between the GCS and the 4 scale. In the GCS, like there are 3.3 level assessment, or 3 parameters are assessing. But in 4 score, there are 4 components are assessing, which include eye response, motor response, brainstem response, and respiratory system. That is E4, M4, B4, and R4. Issue is like, like the GCS has got a limited role in patient on endotracheal tube, or the tracheostomy, or it is misleading, or these are the confounding factors. But definitely the 4 score can be assessed this kind of patients. Again, in ICUs and all, GCS score is less relevant. They are mainly using Apache 2 score, but uh, but in see, like it is all very 4 scores are very useful in detecting patients with lock syndrome, particularly in ICU. Other thing, it is the GCS is well validated for the last 30 years, but the 4 score yet to be need more validations. And finally, we are coming to the PECAN rule. PECAN rule is basically used to decide the CT scan, whether the CT scan is required in a pediatric cases. So these PECAN rules are again is different for those children who are below 2 years and those who are above 2 years. So in a simple version, the PECAN rule is assessed by, if suppose the baby is less than 2 years, what you have to assess, you look at how whether the 3 things you are look at, whether there is a altered mental status, or how if the GCS is less than 15, or there is any palpable skull fracture. If this is there, definitely that child is required or indicated for a CT scan. But coming to an age above 2 years, the GCS and AMS are same. Rather than looking at a palpable skull fracture, you look for the any signs of basal skull fracture. If any one of these are there, again you should go for CT scan. And if this is not there, again, the next what you have to look at, if the patient is less than 2 years, you have to look at whether the LOC is more than 5 years, or there is any frontal hematoma. Is there any frontal hematoma, or a non-reacting patient is not acting normally, or there is a severe mechanism of injury? If any one of these is there, yes, you have to put the patient on observation, or the observation versus CTs can be decided if it is less than, depending upon the physician experience, multiple or isolated finding, worsening symptom or signs in the ED observation, or if the child is less than 3 months, and the parental preferences. But if the child is more than 2 years, what you will do, like you see that history of LOC, history of vomiting, severe headache, or severe mechanism. If this is the, you decide whether like to be observe or to the CT scan. The CT scan, whether to take CT scan is again in a child more than 2 years, depending upon the physician experience, multiple versus isolated finding, and worsening symptoms, signs and symptom in ED observation, and also parental preferences. So these are the 4 things I quickly explained. Thank you for your patient listening. Any question you can ask now. Thank you.